अस्सलाम वालेकुम। आज जो है हम प्रोजेक्ट एको के सेशन में बात करेंगे इन्फेक्शन रिलेटेड जीएन. So Dr. Masood, without any further ado, why don't you take over?
Okay, thank you. Basically, if you saw the previous, we said that we're going to talk about post-infectious glomerulonephritis. So things have changed from that particularly terminology in recent years. So when we used to talk about post-infectious, that was only post-streptococcus used to come in mind. But now things are, for the last couple of decades, things have changed. We have seen that very, not uncommonly, other bacteria also causing infection, and we'll talk about that. Some of those are not post-infection. Actually, it's glomerulonephritis happens when the active infection is already going on. So we'll talk about that. So this, because this is Ramzan, I think the participants are less in number, and I can tell you that I personally don't have much experience with the post-streptococcus. First of all, it's not very common in adult population. I mean, sometimes described in elderly population, but mainly it is a disease of the children. So I'm here to get myself educated from the people who have a little more experience about dealing with the post-streptococcus infection. And particularly if any pediatric nephrologist is there, I'll be like to share and learn from him or her. At the same time, I want to make it a little more interactive. As I told to Dr. Farooq that please don't wait for any question till the end of my talk. I'd like to be more interactive with Dr. Farooq. We'll be checking if you raise your hand or put in question in the chat, and we'll talk about that. So when we talk about infectious-related glomerulonephritis, we're talking about bacterial infectious-related glomerulonephritis. There are four conditions more commonly, and we're going to talk about that. One of them is post-streptococcus GN. Other one is Staphylococcus-associated infectious-related GN. That is mainly disease of the adults, and which we see, but again, luckily, it's not very common. But we have more knowledge of it in the last couple of decades. After that, it was not much described. And then we have endocarditis-associated GN, and then shunt nephritis. Next.
Are you able to see the slide has gone to the next one?
Actually, I can move also. Can you
okay.
See
yep, I think because you are the co-host, so you can do it.
Oh, that's good. Okay. So as you can see, many bacteria and some parasites and viral can cause GN, or not GN, renal insufficiency or renal effect, but we're going to talk about mostly we're going to talk about bacteria related. So when you go to pathogenesis, there's some difference, we will talk about that, between streptococcus-induced GN and staphylococcus-induced. But some basic things are similar, some are different, we will talk about that. So similarity is that in streptococcus and staphylococcus, that is caused by bacteria triggered by that. In post-streptococcus, there are some antigen produced by the streptococcus, group A streptococcus, and that are deposited in the glomerular basement membrane, where they trigger the antigen antibody reaction, and that triggers the pathogenesis of post-streptococcus GN. That happens a couple of weeks after the infections, either pharyngitis or skin infection. And at the same time, same thing like streptococcus also triggered antigen, which caused antigen antibody reaction. But in that case, the antigen antibody formation is in the serum, and that is deposited in the GN or basement membrane, and that triggers the antigen antibody reaction, and then complement system triggers and then cause inflammation. So let's talk about post-streptococcus GN. Basically, the diagnosis is not important, but I think when I come to, and the treatment is also not very complicated. It's basically, we're going to talk about that, how you differentiate those conditions which are closely related, but how to differentiate, because the treatment is different. When you have some other condition in which the immunosuppressant medications are indicated, while in post-streptococcus or even staphylococcus induced, this is not the case. And that's why it's important to have the correct diagnosis. So in the post-streptococcus GN, that is caused by nephrogenic stain of group A streptococcus, there are two antigens which cause the problem. One of them is here, yes, nephrotic-associated plasmine receptors. And the other one is Streptococcus pyogenes exotoxins B. That is found to be more common as compared to NPIR. And also there are different mechanisms. So one mechanism is that because of some enzyme produced by the Streptococcus, it can modify IgG, which becomes auto-reactive and cause autoimmunity. So that's the other mechanism is caused. So this is a...
Which slide? I mean, I think we are now, the slide deck is not moving. I think I have to move. So you have to tell me.
Oh, okay. So let's see the next slide, which is showing the...
This is the viral infection slide.
Oh no, slide which showing the light microscopy.
This one?
So able to see that light microscope slide?
Yeah, we see the light. So please tell me, I think we missed some of your slides as you were presenting.
Okay, that's fine. There was not much.
Just let me know when to just click next. Now we are seeing that light microscopy.
So this is light microscopy. So I just want to differentiate, which is very light microscopy, how you differentiate that what happens when you have a post-streptococcus infection. So next slide. This is showing light microscopy in a patient with post-Streptococcus glomerulonephritis. It's very obvious that there's a marked cellular proliferation, and so you can see a lot of cells in the capillary and some mesenterium. This is basically neutrophils and some monocytes. So this is typically, you see, there is no difference between post-Streptococcus GN and post-Staphylococcus or Streptococcus related GN when it comes to light microscopy. You see the same thing. Next. So this is a normal electronic microscope. You can see that nicely. There is a very like a thin basement membrane, and this is a capillary human. There's endothelium, and there's a podocytes. So next slide. What you will see, this one is a patient with the post-Streptococcus GN, and the very prominent finding you see that this is basement membrane, which is thicker, and this is a subendothelial deposit, which are hump. These are antigen antibody complexes, and this is a very like prominent. This is not very. It's not specific for this form of infection. It can happen in other diseases also, but this is very commonly seen in post-Streptococcus GN.
So Vas, would you just walk us through the this slide, because this is important. I think the location was subepithelial, right?
Yes.
So maybe
yeah, this is a capillary human, this is a neutrophil, and this is the basement membrane.
So neutrophils is this one. So this is the urinary space, and this is the basement membrane. So
basement
these are the deposits.
And these are like subendothelial deposits.
Are they not subepithelial to me?
Sorry, subepithelial, right? This endothelial, this is epithelial, subepithelial, absolutely. So yeah, this is, and that's really the difference between when we talk about the differentiation of the different condition, subepithelial or subendothelial deposits. So this is subepithelial deposit, and this is the urinary space. So very prominent. Yeah. No, it's not.
No.
Somebody need to mute.
Yeah, let me see if I can mute.
अरे भाई क्या ना तुम अपने इतना सर दर्द बढ़ाते हो, बस जाने तो जाने.
Okay.
I don't know where the.
क्या है?
अच्छा, मैं मिल गई. Okay, I've done that.
Okay, so next slide.
Yeah, this is the other slide, the follow-up and electron microscopy.
So again, you see that this is a subepithelial deposit, very prominent hump. Okay, and subepithelial.
Yeah, I think
Again,
wherever you got this slide, this looks like very nice. You can see you can track the basement membrane through and through, and then these deposits are super prominent in this space.
Absolutely. Okay, but you see this is some subendothelial deposit also. You can see sometimes.
Mm-hmm.
These are very prominent subepithelial deposits. Next slide. This is a very unusual presentation of post-streptococcus. This is a massive subendothelial. It can also happen sometimes, but this is a very unusual, but sometimes you see that. And next slide. Yeah. Immunofluorescent slide. So in that case, you see that C3 and immunoglobulin deposit also. So immunoglobulin deposit, mostly IgG deposits. In the case of post-streptococcus, when you see that Staphylococcus-associated, when there's an immunoglobulin deposit, there are IgA. So that's why many times the IgA-related Staphylococcus infectious glomerulonephritis also a deposit. So these are some dysmorphic, next slide, some urine, some dysmorphic RBCs. And the next slide is the RBC casts. And next slide, clinical presentation. I will not spend much time on that, but so because of GN, there's hematuria, there's proteinuria, and hypertension because of salt retention. And edema is common because hematuria is common, but not always. Some cases are just like microscopic hematuria, some are gross hematuria. So it depends on presentation or severity of the condition. So next slide is the lab finding renal function abnormalities, hematuria, proteinuria. Proteinuria most of the time in post-streptococcus, most of the time is not nephrotic vein, but significant proteinuria. But unless you folks have a different experience over there, because again, I don't know, for Dr. Farooq, when was the last time you saw post-streptococcus GN here? I mean, I don't recall. I mean, long time ago.
Yeah. So what the typical case presentation which we have is somebody who has endocarditis, already established endocarditis.
Yeah.
Now they are in acute renal failure, which is
So,
progressive. So you do see rise in creatinine, you do see volume retention, you do see some hematuria, which hematuria is prominent, and proteinuria is like subnephrotic, less than a gram, 200, 300, 500, up to a gram. And their complements, one complement is normal, the other complements is slightly low. So the and really the conundrum is that is this infection or is this
definitely, it's very important. We're going to talk about that
because
in a minute, like how to differentiate. So
yeah, so in those patients, what we also see sometimes the ANCA titer is indeterminate. So you send an ANCA, it says indeterminate, whereas MPO-PR3 are negative. So since you asked me, so that's the type of patient where we contemplate or entertain the diagnosis of post-infectious GN. But then there is also like on the balancing side, is this inflammation? Is this some other autoimmune process?
Absolutely.
Maybe if you can ask somebody from colleagues from Pakistan, like when they see very classic post-infectious GN, how does this present?
Umar, can I first ask you, what do you mean by indeterminate ANCA?
So the lab, so this is about the screening ANCA. So they say that like they are unable to determine whether this is absolutely negative. They sometimes actually give that, they don't tell us C or P, but they say it's indeterminate. The titer is on the low side. So they see maybe some ANCA or something that looks like on the ANCA with that screening test. But when we do the ELISA confirmatory, like MPO or PR3, those are negative. So it's really, sometimes this is how it's reported on within our lab. We have spoken with them. I think they see some background activity related to ANCA, which is not enough to meet the threshold, but there is still some kind of a bar in the lab.
Yeah. Okay. Well, yeah. Again. So basically, these are labs you order. You order renal function test, you order urine test for hematuria and proteinuria, and you order complement. And for 90% time when you have post-streptococcus, because it's a lectin or it's a alternative pathway is involved. So you see that C3 is suppressed, while C4 is not suppressed most of the time. And you also order a culture, but post-streptococcus is next slide, serology. They mainly is diagnosed by serological test to see the antibodies to antigens in patient's serum. So you can order a streptomycin test, which will show different antibodies against the antigens. But you can also order, depends upon availability, like individual antibodies. And in that case, next slide is most commonly you will see when it's related to pharyngeal infection, like a couple of weeks before the presentation, the ASO titer is high, or anti-DNAs or anti-NADs. While because of skin infection, mainly you see anti-DNAs, B, and AHAs. So let's talk about differential diagnosis. I think that's more important. So what are the conditions when you see a child or adult with you're suspecting a patient presented with hypertension and nephritic condition like hematuria and proteinuria, and then you can see that there are other possibilities also. As I said before, it is important to differentiate from the other closely related disease because the treatment is different. Whether the patient needs immunosuppressant or not, that we have to diagnose. So like a C3 glomerulopathy. What are the common things that are with the post-streptococcus? That C3 glomerulopathy, which is like a dense deposit disease, or C3 glomerulonephritis, they can also present after infection. Okay, sometimes. And they also, you will see proteinuria, hematuria, and increased creatinine. Okay. And the complement also low in that case. So how you differentiate? Clinically, patients in post-streptococcus glomerulonephritis, typically, not always, most of the time, it's a short-lived disease. I mean, it recovers most of the time after a few weeks. While if you have C3 glomerulopathy, in that case, it persists beyond 6 weeks or until patient get a proper treatment, it will not improve most of the time. If you go by biopsy, you will see there will not be, you will see that in light microscopy, you will not see that cell infiltration like you see in the post-infections, like neutrophil monocyte, you will not see. And also you will see most like a dense deposit of an immunofluorescent of C3 with very little, sometimes no immunoglobulin, IgG, or even IgA deposit. So that's the thing. In IgA nephropathy, it also can present with hematuria in a young adults or child with IgA nephropathy that also present with hematuria, proteinuria, hypertension, all those symptoms. But clinically, it can present after infections also, but most of the time shortly after infection, like less than 5 days or not. And also, in that case, if you do complement, typically IgA nephropathy, you don't see suppressed complement. And most of the time, there's a previous history of hematuria also. And while post-streptococcus, most time is one-time disease, it does not recur that often. So IgA nephropathy, there won't be any suppressed, typically there won't be any suppressed complement. There won't be any previous history of hematuria. And when you do the biopsy, you will not see that that typical light microscopy, you will not see typical infiltration of the neutrophils. And if there's a deposit, there'll be more like deposit, some you can see in mesangium. So that's why it differentiates from post-streptococcus. As for the next slide, acute management. I want not to spend much time on. Typically, is the antibiotics. If patient is penicillin sensitive, then penicillin. If penicillin allergic, then erythromycin is given. Otherwise, supportive treatment. If patient has edema, loop diuretics, and patient has hypertension, treat the hypertension. Typically, calcium channel blocker or other available blood pressure medication. So that was about post-Staphylococcus glomerulonephritis. Any question, any comments? I mean, again, we in US, we don't have much experience about that. I don't remember the last time I saw a patient with post-Staphylococcus other than after endocarditis. Probably have seen, but it's not common at all here. And 97% cases world over are basically, they are described in the developing countries.
So can I comment?
Sure, please.
Yeah, thank you very much. Actually, I just saw recently a patient, young, about 19 years old girl. She came in with just history of swelling, and for about like 2 weeks, the family, they just, were doing some home remedies and stuff, and then they came to me. And it came out to be, like ASO titer very high, more than 400. She didn't have any much of a proteinuria, and there was some hematuria. Probably it was a resolving phase, because another week or so, she was quite okay. She had a very high blood pressure, and typically, the features as you were telling. So this one I saw just after, I think, many months. So post-streptococcal is there, in our community. We do see it, but not very frequently. Because probably, anybody who gets an infection just gets antibiotics right away and is eradicated. So it does not turn on the whole scenario of the infection and immune complex mediated issues. So her C3 was very low, and the C4 was normal, and so it was like a typical. Similarly, we have seen many patients of post-infectious other than this post-streptococcal, but we can't pinpoint, whether it is a virus, a bacteria, what kind of because of the shortcomings in terms of diagnosis. And but majority of them, other than the post-streptococcal, they don't present like a simple cases of post-infection. They'll just go away. Many of them, they end up getting a biopsy, and they have a quite significant disease, glomerular disease, a lot of inflammation, there's scarring by the time we do the biopsy. So post-infectious other than post-streptococcal, in our experience, I don't know, I mean, what about my colleagues? But I think what we have seen here in our center is that usually it's not as a simple post-infectious, other than in very early few cases. So it's kind of a disease that's going to end up in CKD and later on dialysis.
Yeah, absolutely. Again, post-streptococcus is not very simple. Actually, many patients, they don't recover fully or don't recover at all, even with post-streptococcus, even your diagnosis is correct. What happened that when you have acute damage to the glomeruli, some are sclerosed at the time, and then others are hypertrophied. And there's some, because of that, there's some sclerosis built in, and they actually continue to have CKD. And then with the progress, with the passage of time, it can get worse or it will not improve. I don't know, when you have patient, will you think that patient has post-streptococcus after a few months, and patients still have hematuria, proteinuria, and you biopsy show that it's not IgA or it's not C3. I know how you would treat that. There has been some case reports of giving patients steroids, but only like very individual case report. There's no study shown any benefit of that. So Anybody has any experience of giving steroids to patients who did not improve as expected?
Yeah. I think, Dr. Masood, thank you. We have a relevant question regarding the use of steroids by Dr. Hina. I know Dr. Aurangzeb, he raised his hand. So how about if we go to Aurangzeb first, then I will pose the question by Hina, and then we can have a discussion. Actually, there's a very good point by Dr. Farman as well. So let's, Aurangzeb, you go first, and then we will discuss those two other questions in the chat.
Yeah, the two questions in the chat, they are very important, and I think they are one of the important learning points for the session. And I'm sure we are going to learn whatever the different perspectives we have in different practices. Post-infectious journey is not that uncommon for us. For example, I think for each week in my government OPD, usually we tend to have a patient every other week, if not any, not more. And usually when the patient is presenting in the childhood age, it's generally a very benign course, and the prognosis seems to be better. But the tricky part is when the patient is having a post-infectious GN and a suspicion of post-infectious GN in an adult patient. And that was the dilemma that we faced when I was in Lahore General Hospital a couple of years back. So we diagnosed almost 3 cases of C3 glomerulopathy, and there was a confusion. Either it's a C3 glomerulopathy or it is just a resolving phase of post-infectious GN. And after 6 weeks, the immunoglobulins tend to resolve, but the C3 can be sticky and it can remain there for the next few months. In that case, we came up with the paper that I shared a couple of months back that we presented in Dubai too. So in that, what we did was, and this is a routine protocol for all the patients that are diagnosed as C3GN from my department, that we tend to get a C4D staining for them. So if the C4D staining is positive, then C3GN does not result in mannose binding lectin pathway activation. So C4D staining tends to, or I should say, it may help in differentiating in those conditions. A positive C4D would point towards a resolving post-infectious GN, and there may be some scarring, there may be some residual renal dysfunction. On the other hand, a dominant C3 staining without C4D, probably we should be looking for monoclonal gammopathy of renal significance and things like that in adult patients, and it may not be post-infectious GN. And the noisy diagnosis is made because of the fact that usually there is some sort of infection during the disease process, and a lot of patients had some LRTI in the last couple of years. And every time they got a little more sensitive, and previously about 2 to 3 years back, they should not report the mild symptoms of LRTI. But for the last 2.5 years, every patient tends to highlight if he had a mild symptom of sore throat. It may not be causally associated with that GN. So I'll be sharing that paper on the group 2. And the rest of the discussion points, I think they will be highlighted once you answer the questions in the chat.
Very nice, very nice. Definitely, this is a dilemma when what to do with this kind of presentation, which persistent complement, low complement after a few months. So basically, when you have, this is a very atypical presentation, which we face sometime, but typically when you have post-Staphylococcus, the first thing which becomes normal out of all hematuria or proteinuria or complement, I think complement comes close to normal in typical, while in C3 glomerulopathy, it persists obviously low for a long period of time. Hematuria and proteinuria can take some time before they abolish. So, Dr. Farooq, any other?
Yes, I think let's keep the discussion. So, Aurangzeb, getting the C4D for this
yeah, that's a very important point.
It's a smart idea. I don't think I have seen
that's why
C4D out of the transplant
I'm
world.
glad that people who have experience.
If I may add, this trend was, I only saw that in a Mayo paper, and it was published in 2017, but it did not get a lot of attention. And I think for the first time in subcontinent, we have done this study, and mashallah, our PG presented that in Dubai, and it was given second prize, if I'm not wrong. Yeah, a second prize.
I'm not surprised. This is very, very important point.
It's a
and
unique idea to use
Yes.
another test for this condition. So on the same lines, let's discuss Dr. Hina's question, which is, let me read it out to you. It says that, have you ever seen a patient who has typical post-streptococcal GN alongside nephrotic range proteinuria? I assume, Hina, the patient also had nephrotic syndrome. I assume that. So patient with 5-gram proteinuria, no biopsies done, and also ASO titer of 10,000. Patient was given steroids and responded very well to proteinuria. So really the thing is, what is the actual diagnosis? So can these two conditions coexist? They can, as we just heard that sometimes the infection is part of the pathway of any other primary GN. So the question is the infection which is triggering everything else, or infection happened afterwards? I don't know how best to explain a very high ASO titer. The sensitivity and specificity of this test was in question in the past as well. So I can let me share another aspect. So we had a patient, some similar confusion with vasculitis, and that patient biopsy was very helpful, and the posse-immune, there were no immunofluorescence was completely posse-immune, and so we actually treated that patient with steroids as if this was vasculitis. After the blood cultures had resolved and patient was clinically out of the acute infectious phase. There was another patient who we had the biopsy done, and it actually showed very classic pattern of injury of infectious GN on the biopsy. So we just did not treat this patient with steroids, focus on infection, and patient actually recovered and did very well. So anybody else wants to take this question by Dr. Hina about when you have a patient who have nephrotic syndrome and also has ASO titer and you didn't do biopsy, how best to handle this? Dr. Tarif, maybe can I volunteer you for this question?
Yes, sure. Well, I mean, if you have an ASO titer that is so high, up to like 10,000, I don't know, I mean, whether all this, the proteinuria, everything went away spontaneously, or, this is just a response to the steroids. Many times such patients may receive certain medications that may cause interstitial nephritis along with that, and that may help in terms of taking care of this element in these patients, because we have many patients who are coming in from one to the other to the third one, and many quacks in between. But in terms of the proteinuria, yes, if it does not improve, if it is in nephrotic range proteinuria, a lot of swelling, I would tend to, give some steroids and see, what happens.
Okay, and the biopsy, at what point do you think the biopsy is a must?
Well, if there is a proteinuria and it is not improving, I would just go ahead for the biopsy. That will just further support whether this is a post-infectious etiology or we are missing something there. Because we can't just, order all tests, including, ANCA in these patients, along with the ASO titer would be sent. But, if there's some underlying disease there which was not picked up before, and just the patient presented on top of it, with the post-infectious GN, that could be another possibility there. So
Thank
biopsy,
you.
I think, is must in this patient.
So really the dilemma we are discussing is the differential diagnosis and accurate diagnosis, because I have, for example, seen some cases in association with this ANCA I described. You may have seen some other associated things, for example, interstitial nephritis, and Hina responded that patient C3 was low and ANCA was negative. So it looks like from these tests that there was a big possibility of post-infectious GN. Proteinuria may or may not be related, but patient responded to steroids, what if so imagine if you did not give steroids and patients still responded. So this goes back to the hierarchy of diagnosis in that case was probably post-infectious.
If I may add a point, sometimes it happens so that the patient is receiving, just like Dr. Namantri pointed out, that the patient may be going to quacks and receiving some NSAIDs and things like that. So minimal change disease on a back end of some other disease can coexist. And there have been so many case reports on it. And generally, both of these things tend to do better if the patient is receiving a steroid. I'm not advocating, I personally don't use steroids empirically most of the time, but sometimes, especially in Pakistan, the patients tend to say no to renal biopsy more often than not. So in that conditions, yes, steroids may be opted, and renal biopsy should be done if the patient is presenting with nephrotic syndrome with a suspicion of post-infectious GN. And that's what I do if there is some that sort. And
Also,
ultimately,
yeah, go ahead.
and also one of these patients ultimately turned out to be a C3 GN. If I remember that patient, he was a father of my hospital employee. And later on, he was maintained on MMF. And he did well.
Yeah, basically C3 glomerulonephritis are complement dysregulation, and so this condition also post-Staphylococcus or Staphylococcus-associated GN tend to happen people who have some genetical or acquired complement dysregulation. So that is possible that the patient was persistent and continue to have complement dysregulation, and steroid did help in that case.
So, Dr. Aurangzeb, I mean, can this be a IgA nephropathy which responded to steroids? So steroids, I mean, IgA can present very similar features to post-infectious GN in terms of, the clinical features, and you could potentially have an ASO positive too if the patient had recent infection. One of the first-line treatment for the people with proteinuria and IgA is actually steroids. So without a biopsy, it's quite possible this patient had IgA nephropathy and was treated with steroids or responded to steroids.
Typical IgA doesn't present with C3 suppressed complements. That's the other thing.
Yeah, nephrotic presentation of IgA is only 5%. It's altogether possible. I'm not saying that it's not possible, but the likelihood of IgA presenting with a nephrotic syndrome is less. So renal biopsy is probably should be the leading thing in making decision. But yes, it's a possibility that cannot be ruled out.
Yeah, no, I mean, I understand. It's a relatively uncommon presentation of IgA. But I mean, in this particular case, I'm just trying to speculate what could have been the diagnosis. A patient who had a recent infection with strep and was responded to steroids, the proteinuria. So there could be, potential of IgA or some kind of a overlap. I think that's one of the other questions, like IgA overlap with post-infection versus IgA alone. So that could be possible.
If I may add a point, C3 is one of the factors in alternate pathway. For the people having a congenital C3 deficiency, they tend to have more infections. So for somebody to be having a low C3 persistently for some other reason, I am not going into that detail, the chances of infections are out there. So he may or she may be having an additional infection of streptococcus, and just to add to the confusion. And this thing has to be kept in mind when we are making decision in adult nephrology. In pediatrics, probably it's a straightforward decision, and it's a difficult decision when somebody is presenting with a post-infectious differential diagnosis with a persistent C3 low greater than 6 weeks. We need to be very careful.
Yeah, so the take-home message that, immunosuppressants are not routinely recommended, obviously, in this case, but sometimes when you have persistent disease not improving and your diagnosis is not sure, and once the patient is infections-free, and you can think about giving a course of.
Yeah, but the one thing in the C3 is that actually, Dr. Aurangzeb, I wasn't clear. I was maybe didn't get the story about the paper you presented. So the C4D staining you're saying in C3 GN, is that, I'm sorry, I didn't get that part. So is that something you don't see with C3 GN, or you do see it?
Okay, if I get 2 minutes, the first I should explain the pathophysiology, and then I think I will be making myself clear. So the theory
Okay.
is with C3 glomerulopathy, the C4D should not be there because the mannose binding
Right.
pathway is not activated. So lectin pathway, sorry.
Right.
In post-infectious DN, it is usually activated and C4D staining can be found. So if a C3 DN has a C4D staining positive, that should add to the confusion. And this was highlighted. Almost 30% of the cases that were diagnosed to be C3GN previously had C4D positive in our paper. On the other hand, all the patients who were having a C3 dominant post-infectious GN diagnosis, on histopathology in retrospect, we got them out of archive and we stained them for C4D. And we came out that 17% of the patient never had any degree of C4D staining. So they may have been a C3 GN misdiagnosed as resolving post-infectious GN. But I am not saying that this is a confirmatory study. This was a small sample study, but it was just to ignite a new window of cognitive exercise probably. And this discussion needs to be made. And once we have a strong hypothesis, only that's a larger study will confirm these findings. And it wasn't a clinical study because only histopathology was available with Shaukat Khanam, and these patients were dispersed all over Pakistan. So I'm not aware of what was the prognosis. Only the 3 cases that I diagnosed as C3GN, I have been following them, and they were all C4D negative. And one of the patients that I thought was C3 glomerulopathy, it turned out to be C4D positive, and by the course of the disease, it seems like it was a resolving case of post-infectious DN with residual sclerosis leading to CKD.
Okay.
I
So
hope
I guess just to summarize this, basically what I'm getting from what you're saying is that if you have someone who has features similar to post-infectious, whatever, or could be C3, all in the differential, if you do get a C4D positive, then C3, then in post-infectious is less likely. It could still be C3GN. Is that correct? But if it's negative,
Opposite of that.
so the negative predictive value is
negative,
poor.
if C4D is negative, it is more likely to be a C3GN. If C4D is positive, it's more likely to be a post-infectious GN.
Yeah. And Farooq, if you
C3
see that group
But
chat
is there any
on
data? Because
WhatsApp,
I couldn't find any data on post-infectious GN with C3 positive, C4D positivity. You know, is that something you see commonly? Because again, in C3 GN, my understanding is that there's a certain group where you have, I believe it's like 30% people do have C4D positive, even in pure C3 GN, whatever that is called. So that 70% will be negative. So again, the positive or negative predictive values like in that range. But what is the prevalence in post-infectious for C4D? Is that 100% or less than that?
No, it's not 100%,
Please, 100%.
of course. I think the better study, which was the initial study that I read in 2017, was a Mayo paper. I would try to find that and share. It's also not a study where we are explaining everything. But the thing is, if the C3GN, for me, the most important thing is if I'm diagnosing somebody as C3GN, and mostly it will be a case that was considered to be a post-infectious GN, and now 3 months have passed, but the creatinine isn't going down. If that patient is diagnosed as a C3GN on histopathology, I would request a C4D staining. And if it's positive, then I think then the chances are that this is mostly just a tail of a disease. On the
Because
other hand,
इसमें जो मसला है from a clinical aspect is that how to treat these people. So if someone has a biopsy, because in the end, the management is the most important. Like, so, I mean, post-infectious GN, as you know, Wes was saying, is supportive care typically.
That's the point, and that's what I did. The 3 cases that I decided finally C4D negative, I put them on MMF. Decided to put them on MMF. After ruling out monoclonal gammopathy of renal significance and all that, we are not supplemented here with alternate pathway AH50 isn't available. So the MMF generally worked in these cases.
Exactly. तो यही मैं आपसे कह रहा था कि जो because my understanding is also that C3GN is usually treated with a dual therapy like MMF and steroids. And that's
true.
why, you know, जो case उसने student ने present किया था, that's what I was thinking. It's probably a pure IgA or maybe an IgA with low, I mean, complements उन्होंने mention नहीं किया what the complement levels were, but they mentioned ASO positive. So just steroids alone, you know, that retrospectively could have been an IgA rather than a C3. In that case, because उसमें dual therapy use नहीं हुई थी.
No, for sure. I was not talking about that case in particular. Unfortunately, मुझे उसके बारे में बस इतना पता चला था that it was a case of nephrotic syndrome with a suspicion of post-infectious GN and a high titer of ASO titer.
Right.
And I think that case could have been anything, but after steroid responsive nephrotic syndrome is diagnosed, I think we should be a bit more careful, because 5% cases of IgA nephropathy present as nephrotic. Usually 95, they are in the subnephrotic range, if I'm not wrong.
Yeah, you're right. I mean, that is true. I mean, it could have been FSGS or minimal change superimposed on this thing, and which also typically respond to steroids alone. But
And generally,
you know,
one more thing, if your experience you can share, and Dr. Farhan too. If IgA nephropathy presents with nephrotic syndrome, even then the response to steroids is not that straightforward, just like MCD. It takes some time. I do have some experience, and generally it takes some time for nephrotic syndrome of IgA nephropathy. Rarely, if you get it, it takes some time to resolve. I don't know how much time did it take to resolve in this case.
So if allow me to summarize the discussion so far. Two things which I inferred. One is accurate diagnosis, and second thing is timing. So if things are really prolonged and not getting better, I think somebody said 6, somebody said 8 weeks. I think at that time, accurate diagnosis with the biopsy will become utmost important to make the right diagnosis to whatever staining is, and then you know what the prognosis is. So treatment decision will be based on accurate diagnosis, whether to give steroids or other immunomodulator therapy or not. So that's the conclusion. Focus on proper diagnosis, then you can treat.
Okay, so can you go to the next slide?
Yes, it is. We are at next.
Okay, okay. So Staphylococcus-associated. Basically, the difference between post-Streptococcus and Staphylococcus is a few differences. In adults, I don't think that you see much patient with Staphylococcus-associated glomerulonephritis in a pediatric case, but we see patient with Staphylococcus-associated GN in adult case, mostly elderly patient or after 50 is common, and patient who have some underlying disease like cirrhosis or diabetes. I personally know 3 patients over the last maybe 10 years or so, which biopsy proven Streptococcus-associated GN. Again, it's not very common, but that all 3 patients I can see, I remember that those patients have ongoing kind of resistant infection going on. Actually, I have patients just last week, which I did biopsy. I couldn't include in these slides. Is still in hospital. I saw it today, and he also had the same thing. So those patients are older patient who are undergoing in some infection, typically endocarditis or skin infection, osteomyelitis, diabetic patients. So those patients gets this. So those patients mostly present with increased creatinine, and they have actually, many of them have more proteinuria, like nephrotic range proteinuria. And because this is active infection going on, this GN happens when infection is there. There's a continuous production of antigen. And so there's a serum antigen antibody deposits, and their deposit in the glomerulus, and they're triggered a different mechanism, like they trigger the T cell inflammation, and then from that pathway it can trigger the inflammation, or it can trigger the complement system, and that can cause inflammation at the basement membrane level. Next slide.
And
yes. Okay.
And one more thing, the question in the chat was the post-infectious IgA dominant. I think that was
Yeah.
the question.
Yeah, I'll
And-
take that. Yeah.
Yeah.
So this is a pretty much same as I described. The clinical picture is edema and hematuria, and because they're the older patient, they can have nuance of CHF also because of the infection and vasodilation. So when became the IgA dominant Staphylococcus-associated glomerulonephritis, it is seen that many of the patients who has Staphylococcus-associated GN, they have, along with the C3, they have a IgA deposit also. This is some of different when you have post-streptococcus infection. In that case, very rarely you see IgA deposit. With C3 deposit, you see IgG deposit. So there's a little bit difference between the both condition. So
And the tricky part was, I remember the case discussed by Dr. Aga last year, and it was important learning point even for the fellows, that sometimes with infection, IgA can be found in the mesangium. And in that case, we need to hold our horses for any treatment of IgA. That may be misdiagnosed as a simple case of IgA nephropathy and considered for steroid therapy in the presence of infection, which can be a very dangerous bifurcation. Well, misdiagnosed case of IgA dominant post-infectious GN considered as IgA, it's not really easy to diagnose in Pakistan because the differentiating point is electron microscopy and subepithelial humps. So we don't see that. In Pakistan, we just need to rely on our clinical acumen that what's going on, and only the time will diagnose that with antibiotics, the patient is getting better. So probably, and I would like to take that, the feedback from the folks in Pakistan, how would they deal with that kind of confusion?
So let me describe a little bit of differential point between theoretically, then you can have your experience there and you have presentation. So let's differentiate between Staphylococcus-associated IgA dominant GN compared to IgA nephropathy. First of all, if you blood work, you will see that if you have IgA nephropathy, you have less likely to have complement, lower complement. Okay. The other clinical differentiating that if you have IgA nephropathy, patient probably has previous history of hematuria. And in this IgA dominant GN, you have more proteinuria as compared to IgA. But again, IgA also can present with the nephrotic range proteinuria. That's not differentiating point, but complement and also the ongoing infection. If you have infection, which we see many times, diabetic patients, they have osteomyelitis, they have endocarditis. In that case, if that creatinine abnormality happens to be correlated to that, that is most likely staph-associated GN. Other thing that compared to younger patient, it's very dangerous to start with the steroids on patient, and it's even more important to diagnose correctly because these patients, they have hyperglycemia. Like patient I'm treating now, this patient has infection going on. I cannot even think about giving any steroids on this patient, and it's going on for almost a month now. So that's and then obviously if you have like a biopsy, you will less likely to see IgA nephropathy like neutrophil infiltrate or monocyte infiltrate, and also when you have immunofluorescent, you will see that very dense IgA deposit in case of IgA nephropathy, and also the not in case of Staphylococcus associated. In that case, you will see C3 and IgA deposits. And I will show some picture if you how we are able to differentiate rather easily with the different site of deposit humps with electron microscope. Okay, so these are the most common sites of the Staphylococcus-associated GN, endocarditis, skin, osteomyelitis, and all typical chronic and difficult to treat infections in that case. Next slide. So this is just to have a little bit of a differentiating point. Many conditions can present with complement abnormalities. So when you have patient with the Staphylococcus-associated GN, you will see low C3 and normal 4. Okay, when you have patient with lupus, you see that this is basically both C3 and C4 both are low. When patient has mixed cryoglobulinemia, in that case, you will see normal C4, rather C4 will be low, not C3. So as in this slide, that 22% of patients with Staphylococcus-associated GN with or without crescent on biopsy are positive for NCA. That we'll talk about a little bit later. That is mostly patient who we see endocarditis-associated GN, we see NCA, or shunt nephropathy, shunt nephritis. Next slide. I think we spoke about already. This next slide. So this is we have luxury of having electron microscopy. This is a like dense deposit disease. You can see that dense linear deposit. So this is quite easily can be differentiated. It cannot be Staphylococcus-associated GN. I mean, highly unlikely. So next slide. So this is a C3 glomerulonephritis. You see this site of the deposit, this hump deposit. These are subendothelial deposits here. This is a capillary lumen and this is subendothelial, not subepithelial deposit. So this is a differentiating point between C3 glomerulonephritis and Staph aureus associated GN. Next slide. So I have seen patient like this. This is not a patient I have seen, but like I'm describing patient similar to that. Sometimes this is a dilemma comes in how to diagnose. This is a case of a 57-year-old male who history of alcoholic associated cirrhosis, diabetes, and hypertension. He was admitted with a low back pain, rectal bleeding, and some extremely rashes, and oliguric kidney failure, microscopic hematuria, and nephrotic age proteinuria. Next slide. So he had a skin biopsy which showed IgA leukocytoclastic vasculitis, and serum cryoglobin was positive, and there was a low complement C3. So basically, if you go by this, you highly suspecting the patient might have IgA vasculitis, and in that case, patient would need immunosuppressant therapy. So patient had MRI, which showed that he has epidural abscess, and he recently had Staph aureus bacteremia. Next slide. So kidney biopsy was done, which showed that patient had IgA dominant and C3 dominant proliferative GN with some subepithelial humps, not subendothelial, subepithelial humps. So that is consistent with Staph aureus associated GN. Next slide. Yeah, this is the MRI. And next slide. So this is you can see that this is the hypercellularity in the light microscopy, and that's not typical of IgA vasculitis or IgA nephropathy. And next slide. So in this case, immunofluorescence showed that they're both C3 and IgA deposits, and so that's also a little bit different, that you're less likely to have C3, most likely more dense IgA deposit in pure or simple case of IgA nephropathy. Next slide. So here's the thing, in this case, these are deposits, humps, and these are subepithelial deposits. This is a basement membrane, and this is the humps. These are subepithelial, not subendothelial. So that's a differentiating point between C3 glomerulonephritis and whether this patient has Staph aureus associated GN. Next slide. So this patient had renal failure. He was started on dialysis, but after a couple of months of treatment of his epidural abscess, he improved. So basically, Staph aureus associated GN can also present it with some rashes, and that can be misdiagnosed or could be look like IgA nephropathy or cryoglobulinemia or vasculitis. Just a point. So biopsy helps in this case also. Okay, next slide. So endocarditis associated GN. This is a bacterial infection-related immune complex mediated GN. And patient who has endocarditis and renal failure could be because of either because of this GN, or it could be because of septic emboli or renal cortical necrosis. Next slide. So when you have endocarditis and related GN, Staph aureus is the most commonly cultured bacteria. And after that, Streptococcus is the next common, and less common are like Bartonella and other less common bacteria. And some of them very like 9% or low, you will not able to culture any organisms. Next slide. So these are typical, those patients, they have a cardiac valve disease, intravenous drug abuser, or hepatitis C or diabetes. So IV drug abuser, most of the time they have a tricuspid or mitral valve endocarditis, and multiple valves are involved, and many have subacute endocarditis, and so they actually can present with the diagnosis of dilemma because of many unexpected serology. That's next slide. So in that case, positive NCAR test has been reported, and not like a minority, a significant number of patients, and they can have NCAR positive also. Particularly, patient has blood culture positive or infection is caused by Bartonella gram-negative endocarditis. There actually in one case report there were about 60% or 70% cases they were NCAR positive. And is there any significant? What is the significance of NCAR positive? Basically, that happened mostly on subacute case of infectious endocarditis and with multiple valve involvement. So otherwise, prognostically, I don't think there is any significant role of NCAR positive or not positive. Next slide. So in this case, the prognosis compared to post-streptococcus, the prognosis of Staphylococcus-associated GN, or particularly infection endocarditis-related GN, the prognosis of the renal function is not that good. A good number of patients, they end up having end-stage kidney disease, and some actually a good number, like 10-15%, they die because of this serious bacterial condition, because of heart failure and other thing. So even patients who have no endocarditis, just Staphylococcus-associated GN, a good number of patients, they don't recover. I personally will have 3 or 4 patients, and only 1 patient recovered from long term. That also after 2 months of on dialysis. So I still follow that patient. So that's the another prognostic point compared to post-step GN. So patient with endocarditis, I think the other condition can cause also renal failure, drug-induced interstitial nephritis. In that case, less hematuria, can be hematuria, but you won't see RBC cast and mild proteinuria. When you have aminoglycoside, or actually more commonly vancomycin-associated acute renal failure, you have less likely to have RBC cast or heavy proteinuria. And also depends on the level of those medications, gentamicin or vancomycin. You can see that also has to be associated with that. So it's relatively easy to differentiate whether it's caused by GN or caused by these medication nephrotoxicity. Renal emboli you affects months later after that, or sometimes you have clinically you have some pain also, that also in this condition. But again, these are relatively easier to differentiate from these points, but these conditions can cause renal failure in patients with endocarditis. So just a couple of slides, then we can have a little more discussion. So we already spoke to that the prognosis of the patient and renal condition is not that good. A patient who have endocarditis associated GN. Next slide. Just briefly about the shunt nephritis is very uncommon now, thankfully, because of the different procedure is being used for that, for the hydrocephalus treatment. It used to be ventricular vascular when I think shunt was between ventricle and the heart or vessels. But now this shunt is between ventricle and peritoneum, so it's much less likely. It happens after 5 or even 10 years of having that shunt for hydrocephalus. It can present with fever, hepatosplenomegaly, or some rashes like vasculitis, hypertension. Again, there will be decreased complement level and all kind of abnormal serology you can see in these patients, like positive cryoglobin, ANA, body factor. So treatment is mostly infections to take out the shunt and to replace it, antibiotic treatment. That is treatment. Luckily, we don't see, I don't think that I have seen, not remember any case seen from this, or like in radically or in wards. Anyone has any experience of having shunt nephritis? Probably not. So that was all about slides. Any question or any comments? Please, let's open the floor.
Anyone wants to discuss any case which you guys saw?
So I was looking back some of the data on this. So apparently there was a study published in the, we try to send it in the group chat at some point, or maybe in the main chat group, where they showed that 5% of patients with post-infectious GN actually had nephrotic range proteinuria. So this was an old study looking at long-term sort of prognosis or long-term clinical manifestation on these people. So apparently there is a very small percentage who can develop high-grade proteinuria in post-infectious cases. But what treatment should be employed in those patients is an open question. My one concern, based going back to the previous discussion, is, as Omar was mentioning about, one of the key points here in the discussion was about the differential diagnosis, because a lot of these diseases which are in part of the differential have very similar clinical features, and quite a few of them have similar serological features too. So then, for example, Pakistan, without the help of an electron microscopy, if you're relying only on on staining immunofluorescence or just light microscopy, which can also have similar features, then what decision do you make for clinical management of these people? So in other words, one thought is that you wait till the, presuming that this is infectious, and if the ASO titers are coming down, or whatever's, infection is improving, and the renal function is not improving, then biopsy the patient, versus biopsy right away if there's any signs of severity of illness in terms of high creatinine levels or hypertension, other sort of manifestations, and then, make a decision and treat them earlier on, instead of waiting that, okay, this might be a missed C3 case, which we'll treat like 6 weeks later. By that time, there might be significant sclerosis already taken place. So the question is that, should they be treated up front and make a decision up front, in severe cases?
I mean, it also depends on the age group. If a pediatric patient or younger patient who are typically present with post-Staphylococcus-associated, they have laryngitis or skin infection, I mean, all the serology is suggesting that it's post-strep. I don't see any reason for doing biopsy if it's a simple case. While the adults, when we have patient who is suspecting Staphylococcus-related GN, when infection is going on, my approach is to do biopsy always, because in that case, you have more chance of missing some other thing. Obviously, you have to make sure that patient is not bacteremic before you do the infection, but it's recommended that in an older patient, if you're suspecting Staph aureus related GN, you should do the biopsy.
Well, one more thing, I think the age factor should be considered. Probably that what I do. I don't know if it's a consensus or not. Post-infectious GN in a childhood and post-infectious GN in a patient of 50-year-old, it's a different prognostic implication.
Absolutely.
So generally the people presented in the later part with suspicion of post-infectious GN, I would almost always do biopsy.
I agree. Yes. Age is very important.
Probably is I kind of agree to that. In an adult age group, or biopsy is probably the right way, because it's not just the diagnosis, but also your treatment might depend on that, and the patient's prognosis might be significantly impacted, because the treatment for post-infectious and on concurrent infectious GN, this is ongoing infection like staph. Both are classically, the treatment recommended is supportive and basically treating the infection, and post cases, just supportive care. That's it. But when the question is employing other immunosuppressive measures, and so in fact, sometimes even with the biopsy, we discussed like with Dr. Aurangzeb about, like even if you do a biopsy with an adult patient who just had a strep infection, and you don't have, for example, C4D stain there, or you do have it, and then you have the other stuff like C3 is there and everything else. So then there's a question: there's an alternative pathway plus the other pathways are also being activated. But my point is that it might not be resolved completely, especially between C3 and post-infectious, even after a biopsy. So you might have to make a decision.
And let me rephrase how I use it as a tool now. So for a patient who is having a renal biopsy histopathology in front of me with C3 dominant disease, and there is a history maybe of a few weeks, mostly 6 weeks plus history, there are chances that this patient was a case of post-infectious GN, and now the immunoglobulin is just has been removed from the mesangium, and it's just the C3 getting a little more sticky. Now I need to differentiate, is it a C3 GN or a post-infectious GN? If the C4D is positive, so the chances are it's more likely to be a post-infectious GN, and I am just seeing a histopathology when immunoglobulins are removed, but C3 is still there. On the other hand, if the C3 dominant, let's say 3 positive C3 is there, we do immunohistochemistry over here, and C4D is negative, and the patient is almost for the last 3 months with this disease with a low C3, probably I will consider that to be a case of C3 GN. Just do the workup, which in any case we would do.
आपके जो 3 cases है, Dr. Aurangzeb, what happened, like, so which you treated with MMF? I mean, what was the
he shared the paper in the group, Farooq.
Now, let me rephrase that. This is not a clinical paper. The paper I shared with you is a histopathological paper with Shaukat Khanam. The clinical paper is yet to be published because I am just populating these patients. So once they are at least maybe a dozen, I would probably share that paper. So regarding that question, one of these patients had a very dramatic improvement with MMF. He was dialysis dependent when he presented to me, and C4D was negative in the renal biopsy. I decided to go for MMF. He was declared as dialysis dependent, and probably there was chronicity was there in the renal biopsy. But I decided to take a chance. He came off dialysis and started spending his life in CKD 3 or 4. And I think for the last 3 months, he hasn't been following me.
Mm-hmm.
You use steroids plus MMF or just MMF alone?
Regarding that case that I just talked about, because there was a lot of chronicity, so I used low dose steroids orally. I think there was 20 mg to begin with and then reduced to 10. And because he was having a good clinical recovery with the decrease in the active urinary sediments, the proteinuria reduced, the creatinine tend to stabilize, and he was an old chap with diabetes as a comorbidity. So I did not take a lot of chances. In other patient, I think I gave them steroids in full dose for 3 to 4 weeks, and then reduced steroids to minimum within 6 to 8 weeks, and MMF was continued. And there was a kind of mixed response in those, and those were 40 to 55-year-old patients.
Thank you, Aurangzeb. Dr. Tarif, आप please go ahead, and then Dr. Kaisar, आपने भी unmute किया था. If you want to say something after Dr. Tarif, आप भी please.
So, I just want to just clarify one thing, that no doubt, there are a lot of overlap of medications, herbal, this and that, but we should not be, just holding the steroid just to give it to the patients. So we have to use our clinical acumen, even with all the limitations, and see what is the age of the patient, what is the type of presentation, where does it fit, whether there's an acute kidney injury there or not, and whether it is going to, resolve just by a careful observation for a short period of time, and whether there's an underlying infection there or not. So these things should be, so any patient with proteinuria and hematuria and a little bit of raised creatinine does not warrant, just starting the steroids. So one has to look at the whole scenario and then make a decision. This is, just for our colleagues in Pakistan, because we have so much limitations in our diagnostic armamentarium that, we tend to just frequently use the steroids.
Can't agree more, but what would we do if the patient is not agreeing for renal biopsy? In that situation, what's the general policy? I know there isn't any consensus on it, but what's your take on it?
Well, I think, if the patient has a worsening creatinine and there's an element of acute active sediment of urine, and I would just see, whether it is fitting into a pure post-streptococcal or not. If it is not fitting into pure post-streptococcal, then considering all this this thing, you can even start some steroids. But considering you have a normal CRP and there's no active infection there, just to exclude the staph and other things there.
Agreed. Thank you.
Thank you, Dr.
Thank
Kaisar.
you. Thank you, Dr. Umar. Regarding the patients, I think they are mostly overlapping. In pediatrics also, most of them are minimal change, but people, they give them steroids. Even the pediatricians and general practitioners, they do so. And they have superadded throat infection. And then they consider it as post-streptococcal. But I don't think so it is like that. The problem is they give steroids and antibiotics to those patients, and the condition is mimicked or undermined, or what you can say is छुप जाती है, जैसे असल position पता नहीं चलती. And then the problem is rightly said by Dr. Noman and Dr. Jahazeb, most of the people, they don't want biopsy, and our only tool of diagnosis is biopsy for GN. So I usually tell my patients that there are 10 types of diseases which are shown by proteinuria, but you cannot go for the final diagnosis until you have a biopsy. But when they listen, you will take a piece of kidney from that, and I usually refer them to Dr. Noman and Dr. Aurangzeb, sorry. And our position in Gujranwala is very difficult to convince them for biopsy. So I think there are overlapping of the diseases, and even the UTI, they have sometime proteinuria, and they give them steroids. Plus the Hakims and the homeopaths and quacks, they usually give steroids to them, and they recovered from that steroid also for the minimal change disease, sometimes like that.
Yeah, it's not
That
easy to.
reminds me that गुजरात गुजरा वाला शेखपुरा उन्हें क्या है लाहौर ले जाओ। ठीक है। आपने ये भी सुना कि डॉक्टर तारीफ और जो डॉक्टर औरंगजेब अफजल उनकी भी आपने बात सुनी कि किस तरह से बायोप्सी के लिए वो भी किसी वक्त फील्ड स्ट्रैप्ड करते हैं, लिमिटेशन है।
यस यस,
ये बड़े जबरदस्त डिलेमास हैं। आई थिंक जो 2-3 पॉइंट्स जो मुझे टॉकिंग पॉइंट से मुझे इस आज की डिस्कशन में जो मैं याद रखना चाहता हूँ वो ये है कि डायग्नोस प्रॉपरली। दूसरा टाइमिंग, कि अगर चीज़ें इफ़ नथिंग गोज राइट मेक अ लेफ्ट टर्न। अगर आपकी पेशेंट जो है वो आपकी क्लिनिकल एक्यूमेन के अकॉर्डिंगली प्रोग्रेस नहीं कर रहा तो यू मस्ट कंसिडर डूइंग अ बायोप्सी एंड मे बी अ चेंज ऑफ ट्रीटमेंट प्लान एट दैट टाइम। थर्ड थिंग इज कि इन्फेक्शन अगर को एग्जिस्टिंग इन्फेक्शन है, जैसे डॉक्टर मसूद ने शो किया हमें, वो पेशेंट को इतना बड़ा डिस्काइटिस है या वो पैरास्पाइनल एब्सेस है या कोई जॉइंट उसका वो है या एंडोकार्डाइटिस है, तो उस तरह के पेशेंट में इम्यूनोसुप्रेशन का यूज करना काफी डेट्रीमेंटल हो सकता है इफ देयर इज एक्टिव इन्फेक्शन। तो डॉक्टर तारीफ ही आल्सो हाईलाइटेड दैट कि टाइमिंग ऑफ antibiotics and timing of immunosuppression that should be carefully balanced. So ये 2-3 factors जो थे ये मुझे those are my take home points. Avas, do you want to say something in conclusion in the end?
No, I mean, as you said, the more difficult thing in this case, like when I actually started studying on this for preparation for this talk, I never knew that this is a problem because there are so many cases we see which is very difficult to differentiate from each other. And actually, I also learned, I don't know how many I missed that because of lack of knowledge, because we don't have much experience about that. This is relatively a new awareness of Staphylococcus-associated or infection-associated. So these are a few points. Again, we deal with adult patient, and it's very, very important to go for like a definite diagnosis as much as you could. Otherwise, it could be very detrimental. And steroids, definitely in the adult patient, is very difficult to start with because they can do, that could be detrimental. In children and young patient, is probably not that harmful comparatively.
One more thing, I don't know if you have time, but Dr. Kaisar Aurangzeb from Pakistan, one thing which comes out, stands out is the other infectious agents. It's always interesting to me. I don't know, we don't have too much time now left, but in terms of the pathogenesis of these diseases, so the antigens related to staph bacteria or the strep bacteria, what is your experience in other infections? There's a lot of infections going on. We have COVID right now, but viral infections, etc. But other bacterial infections, you see this prevalence of concurrent GN and other cases, viral parasites, bacterials, or post-infectious or concurrent infectious GNs, and how are they treated?
Yeah, I think we still are not there where we have more awareness about that or more experience of that. I'm sure that we missed a lot of those patients because of lack of correct diagnosis. I think the way to go is that obviously culture and find out what infection going on and do the biopsy. Biopsy will tell us exactly that is just some immune related to treatment condition, or it has to be done with infection.
ठीक है, इन दी एंड आपने मरीज को ट्रीट करना है, ना उसके नंबर्स को, ना उसकी बायोप्सी को। तो आई थिंक इसलिए जो है ना आपकी बड़ी
एक बात उमर भाई, एक बात मैं सुना दूं। मुझे मतीन ने बताई थी कि मैं गुजरांवाला बायोप्सी क्यों नहीं करता। इन्होंने शेख ज़ैद में एक पेशेंट की बायोप्सी की और उसको राइट साइड पे बायोप्सी थी, तो उसको राइट सीवीए हो गया अल्लाह की तरफ से। तो उन्होंने कहा कि आपके बायोप्सी की वजह से सीवीए हुआ है। तो इन्होंने 8-10 बंदों ने उनको समझाने की कोशिश की कि नहीं, ये सीवीए बायोप्सी की वजह से नहीं हुआ, लेकिन उन्होंने उसको बहुत ज़्यादा लड़ाई झगड़ा किया कि ये आपकी बायोप्सी की वजह से सीवीए हुआ है। तो हम पेरिफेरी में एक बंदा होता है, वो कितनों को समझाएगा कि ये सीवीए बायोप्सी की वजह से नहीं हुआ। तो देयर आर लॉट ऑफ प्रॉब्लम्स हियर आल्सो, लेकिन अल्टीमेटली डायग्नोसिस तो बायोप्सी से ही बनना है।
I think that was the very strong point that stood out from today's discussion. Accurate diagnosis and biopsy is the gold standard here.
Okay, So
Anybody else has any other thing they want to say before we conclude the session? I think Ramzan bhi chal raha hai, so
उसमें एक चीज है कि जो IgA नेफ्रोपैथी के साथ या IgA related infectious GN है, it is not that uncommon. We have seen a few cases here in our center, so but can be easily missed just because of sometimes they just respond to the treatment and just resolve on its own.
thank you. I think मेरा ख्याल है conclude करते हैं, ठीक है? अगर इजाजत हो अवैस आपकी तो
sure, please.
आपको खुदाफिज कहते हैं, सब लोग सोएं और सुबह सहरी के लिए उठना है सबने जल्दी.
No, actually,
Sir, thank you once again.
This is one of my
And thank-
talks which I actually learned more than I mean gave any information. So it was very, very nice. Thank you very much.
Thank you.
Particular people from Pakistan, and Farooq, thank you too for sharing your experience.
Okay, happy Ramzan to you. आपका तो रोजा है माशाल्लाह.
Thank you so much.
Allah Hafiz. Allah
Okay, thank you so much, Ethan.
Hafiz.
Okay, great. Thank you.